Alright, so another potentially important topic is the fractures around the radial head. You see, there are multiple eponymous fractures which are involving the radial head injury. Alright, so there are several sample questions before we talk about this topic, like terrible triad. It can be very easily asked. You know, three are going to be the options which goes in the favor of a triad. One of the option will be the answer for the question, that which of the following is not a component of terrible triad of the elbow. Similarly, not a potential complication of radial head excision, and you will come to know why excision of the radial head is such an important topic practically, because it is very commonly processed, because it is very commonly done in the management of the radial head fractures. All right, so let's have a discussion on terrible triad of the elbow, or let's start with the discussion with the terrible elbow triad. Now, as the name indicates itself, there are two important components in the definition itself. First is the terrible. Terrible means if this is the kind of the injury the elbow is subjected to, then that elbow will be rendered unstable because it will be having a poor prognosis. Point number two, triad. You see, there are three components in this fracture, and because of this definition, it becomes an important or a potential question to be kept in your examination. So what are the three components of the terrible elbow triad? The first important component is the radial head fracture. Actually, it is not as simple, the fracture of the radial head. It is actually the comminuted fracture of the radial head. That means radial head is fragmented into multiple pieces. Alright. Point number two is the fracture of the coronoid process of the ulna. You see, what is coronoid process? Now, if you try to understand that this is the olecranon process, and here the anterior pouch or the anterior beak distal to the olecranon is the coronoid process. So, if there is a fracture of the coronoid process, it will render the elbow joint unstable. And the third complication, or the third possibility, or the third component is the dislocation. Actually, it is not simply the posterior dislocation. There could be a posterior lateral dislocation or dislocation of the elbow in total. So these are the three components of terrible elbow triad. The first one is the comminuted fracture of the radial head. Second is the fracture of the coronoid process of the ulna. And the third one is the dislocation of the elbow. Now, if you go back to the question that which of the following is not a component of terrible elbow triad, there is a likely possibility that you might consider the fracture of the olecranon to be a component. But in reality, it is never the component for, or it is never the answer for terrible elbow triad. So fracture of the olecranon is the answer for this particular question. Alright. So why is it important? There are two reasons. One, it is a potential question. Second, it will be having a poor prognostic outcome. Alright. There will be a poor prognostic outcome. Why? Because it will render the elbow joint unstable. It is an unstable kind of the injury. Then there are two possible fracture as well as injury to the ligament around the elbow joint. One is known as Yusuf-Lopresti fracture dislocation. Other one is Yusuf-Lopresti fracture in simple. So what is Yusuf-Lopresti fracture dislocation? It is the comminuted fracture. All of you know what the comminuted means. Comminuted means when it is when any single bone is fragmented or broken into multiple pieces. That means two or more than two fracture lines. So comminuted fracture of the radial head with distal radio-ulnar joint instability. Now, one thing that you might ask is that if there is a fracture which is happening in the proximal part of the forearm, then why there will be a distal radio-ulnar joint instability? Now, just try to have a basic understanding of this. Imagine if the patient is having, this is the proximal part of the radius, that means the head of the radius, this is neck of the radius, and this is rest of the radius. And here we are having the distal part. Similarly, this is the ulna and this is the ulnar styloid. Alright. Now, if there is a fracture in the proximal part of the radius, then what it will lead to? It will lead to the proximal migration of the rest of the radius, because there will be no support which is provided or which was provided previously with the intact radial head. As a result of which, the entire radius will be having a slight migration proximally. And once this distal radio-ulnar joint is subjected to a slight proximal migration, it will render this distal radio-ulnar joint unstable, as a result of which there is a instability happening at the distal radial ulnar joint. So this is what the Isak-Lopresti fracture dislocation is. As you can very clearly see, it is not only fracture, it is rather fracture dislocation. That means because of instability at the distal radial ulnar joint. Next is, what is Isak-Lopresti lesion? Now in Isak-Lopresti lesion, what is happening? It is the fracture of the radial head. That means the fracture of the radial head, it could be a comminuted fracture of the radial head with medial collateral ligament injury. Now, there could be an injury to the medial collateral ligament, but there could be an injury to the interosseous membrane also, or interosseous membrane injury. Alright, so this is what the Isak-Lopresti lesion is. Now, what is interosseous membrane? All of you are aware of the fact that it is a membrane which is connecting the two bones of the forearm in its entire length. And if this interosseous membrane is also injured along with the radial head fracture, then it would be called as Isak-Lopresti lesion. So that these are two terminologies, two eponymous fracture dislocation that you should be aware of. These are again a potential question that the examiner can put in your examinations. Next, a 27-year-old male came to emergency after sustaining fracture of the proximal ulna and dislocation of the elbow. Now, we are going to have a discussion on the fresh, that means a subsequent topic. But before having a discussion of that, let's try to understand what is radial head excision. You see, just now we have talked about that if radial head is fractured into multiple pieces, then the possibility of having the union at the fracture site becomes lesser. The possibility of having the stable fixation at the fracture site becomes lesser. Why? Just try to understand. If this is a bone which is visualized from the superior inferior view and it is broken into two pieces like this, alright, radial head is fractured into two pieces. Then after reducing it, it can be fixed by the placement of a Herbert screw. But what if the radial head is fractured into multiple pieces? Then all these fragments cannot be held together by the placement of a single or two screws, by the placement of a plate, pre-contoured plate for the proximal aspect of the radius. In that case, what will happen? Majority of the times, what as a clinician we do, we excise this radial head. Excision of the radial head is performed. Now, what are the possible complications which the patient will be experiencing after the excision of the radial head? So, what are the outcomes of radial head excision? So, hopefully you have understood that why this excision is performed and then what are going to be the possible complications related to this radial head excision. One is proximal radio-ulnar joint instability. Alright. So, there will be an instability in the proximal radio-ulnar joint. That is one thing. It is obviously going to happen. Second is the distal radio-ulnar joint instability. Now, you already came to know that if there is an excision of the radial head, then there will be a proximal migration of the entire radius to some extent, which will result or which might result pain in the wrist also. So, distal radio-ulnar joint instability. The third one is valgus deformity. Now, why there is going to be a valgus deformity? Just try to understand. If this radial head is excised, so there will be a no support which is provided on the lateral end of the elbow. As a result of which, there will be more bending of this elbow laterally. So, this is the reason why the patient could have the valgus deformity or the valgus abnormality at the level of the elbow as the outcome of the fractures of radial head excision. Alright. So, these are the three possible outcomes related to this. Now, if you go back to the question that was placed, a sample question is that which of the following is not a potential complication for radial head excision? Now, if we look at the options, the first option is valgus, which yes, it will happen. Instability, yes, there will be an instability both at the proximal as well as distal radio-ulnar joint. There will be a wrist pain, yes, there will be a wrist pain associated with the distal radio-ulnar joint instability. But restricted supination, actually, there is no restriction of either supination or pronation because radial head is not providing attachment to any of the muscles. Alright, no muscle is attached directly onto the radial head, as a result of which there will be no restriction of supination and pronation. So this is something which you have to remember very importantly, that if at all this question is kept in your examination, that this will always be kept as the answer for your question, that in radial head excision there will be no restriction of supination or pronation. Alright, as far as elbow movements are concerned, it will be absolutely normal. So hopefully these topics means fractures of the radial head are understood in a better or a possibly how the questions could be kept in your examination. In that way we have already understood that. Now comes a very important and very commonly kept question in your examination about Monteggia and Galeazzi. Now before we talk about these fractures, let's have a discussion on the question, that how the question is going to be kept. Like 27-year-old male came to emergency after sustaining injury. That means there is a fracture of the proximal ulna with dislocation of the elbow. So they have mentioned clearly that the patient is suffering from Monteggia fracture dislocation, because subsequently we are going to talk about the definition of this Monteggia fracture. On examination, the metacarpophalangeal joint extension is lost. The patient is not able to extend the metacarpophalangeal joint and the affected side, but the sensations in the hand were intact. What is the most probable diagnosis? Alright, so you leave this question, then we are going to have a discussion on this question again. Next, they just gave you the X-ray and they are asking about what is the possible diagnosis for this condition. Alright, so let's have a discussion on the next topic, which is again very, very important topic for your examination, and that is Monteggia fracture dislocation. Now under this heading, there are going to be 4 parts. The 4 parts that we'll study is, the first one is identification. That means definition. That means what is Monteggia fracture dislocation? So Monteggia is, it is the fracture of the proximal ulna. It is the fracture of proximal ulna with proximal radioulnar joint subluxation or dislocation. Alright. Subluxation means partial dislocation. Dislocation means complete displacement at the joint. So there is a fracture of the proximal ulna with proximal radioulnar joint subluxation or dislocation. That is the definition of Monteggia fracture dislocation. Next is the classification. Now what is the name of classification? Classification is Bado, B-A-D-O. Alright, Bado has classified the Monteggia primarily into 4 different types. Now the type 1 is anterior. You just have to remember the type 1 is anterior. The type 2 is posterior, the type 3 is lateral, and type 4 is slight variant of the Monteggia. Now just try to understand that what are these 2 components, that the radial head dislocation and the apex angulation. What are these 2 components of this Bado classification in Monteggia fracture dislocation? Alright. In order to have a basic understanding of this type, you just try to understand one thing, that if there is a fracture of the proximal end of the radius, then in which direction the elbow will be dislocated. This is what the essence of Bado classification is. Alright. For example, if I say that if the proximal radius is apexed anteriorly, for example, after getting the fracture, the proximal radius is apexed. The apex of the angulation after the fracture is anterior. Then in what direction the radioulnar joint will be dislocated? Answer to that question is also anterior. The dislocation will also be anterior. Now why? Why the dislocation is also anterior when there is a apex angulation that is anteriorly? The reason is the interosseous membrane. Now all of you are aware of the fact that both these 2 bones are connected by an interosseous membrane, and if there is a fracture which is responsible for anterior apex angulation, it will pull the elbow anteriorly. Similarly, if the fracture is posterior, as you can see here, the fracture is posterior, then the dislocation will also be posterior. Similarly, if the apex is lateral, then the dislocation also will be lateral. But the 4th one is a variant. Variant means it is not the medial subluxation or medial dislocation or the medial angulation of the ulna. It is simply the fracture is anterior, but there is a fracture of the both bones in the proximal aspect. That means both radius as well as ulna are getting fractured into the proximal aspect. Then it will be classified as Monteggia type 4.